Thank you, Alison. Right, I shall just share this. There we go. Okay, so thank you everybody for coming along this evening. So we're going to talk to you a little bit more about axial spondyloarthropathy. And we've got three presenters who are three researchers, but we're also very, very lucky, and we've got some of our patients who are also going to give us some valuable views on their experiences as well. So the first part of our talk will be Dr. Arumugam Moorthy, who is a consultant rheumatologist at University Hospitals Leicester. He's going to talk a bit more about what axial spondyloarthropathy actually is. I'll then talk about exercise in axSpA management, and particularly about maybe looking at exercise in a slightly different way in seeing if it can be an anti-inflammatory therapy in AS. And then our colleague, Dr. Matt Roberts, is going to talk to you about our study, our NASS-funded study, the ecstasy study, and share with you some of our preliminary findings. And then, as I said, I'm really, really pleased that some of our patients who are involved in the ecstasy study have joined tonight and will also hopefully share some of their views. And then we'll take questions at the end. So without further ado, I'll stop sharing and ask Dr. Moorthy if he would like to share his screen, and hopefully you'll enjoy our talk, and hopefully we'll teach you something about axial SpA. Thank you.
Hello. Hello, good evening, everyone. Can you all hear me?
Yes. Yes.
Okay, thank you. Thank you for coming along to an educational evening. So I'm Dr. Moorthy from Leicester University Hospital. I'm just going to talk you through about what is axial spondyloarthropathy. The axial spondyloarthropathy is very common chronic inflammatory conditions affecting predominantly the axial spine, sometime in the peripheral joints. They can present as a back pain associated with stiffness in the back, and due to the inflammation, they also have extreme fatigability. It's not very uncommon condition. It's a very common condition. Now, it is estimated around 1 in 200 people do suffer from this condition. Now, this condition, there is a huge delay in diagnosing this condition, up to 9 years in the general literature, what we suggest. If you can see that 23 years ago, this paper is published, which has clearly shows there is a delay of picking up this diagnosis. As you all might know about this National Axial Spondyloarthritis Society, if not, please visit. You will get lots of information about this condition, and it can promote about the health awareness of this condition in UK and internationally. What they know from us in England, it is still 8.5 months, 8 years and 5 months is the diagnostic delay, or if somebody has got back pain, before they labeled or diagnosed of axial spondyloarthropathy, is 8 years and 5 months, which is still 20 years ago, it was like that. Now we are in 2023, it's still there. So that is why we are concerned as a clinicians, why we are concerned about this. These 10 to 14% of people have this condition, but only few of them seen the doctors. And because of this condition, a lot of people have retired earlier than general population because they couldn't go to work. Most important thing is this condition affects predominantly those people in the productive age group, i.e. they are in the middle part of their life, or the type where they can go to work and earn. And there is 22% reported as presenteeism, and 3.5% with axial spondyloarthropathy reported absenteeism at work. There's a huge amount of cost implication due to work-related absence, which you can see that 11,000 per person per year in axial spondyloarthropathy on that one. Now, What is we found on that one is we have a cost of individual, particularly due to the delayed in diagnosis. As I told you, 1 in 200 people in adults in the UK have axial spondyloarthropathy, but they're not diagnosed in time. This is what happened. Nearly £196,000 is cost to the general population and economy of that one. As I told, the average delay is 8.5 years and productivity is less, and out-of-pocket expenses to travel to appointments and medication and treatment. There are direct costs and indirect costs to the both national health services as well as the particular person who suffers from that. There's a huge amount of economic impact on this condition, which one should bear in mind. So that's why the National Ankylosing Spondylitis Society, Axial Spondyloarthritis Society, and we as a clinicians are working on how to drive down the diagnostic time delay. As a Leicester, we have done a lot of work, and we have reduced the delay from 8.5 to 3 years in Leicester. This is due to the change of care process we deliver and influencing of thinking process with both primary care, secondary care practitioners, and also policymakers and other healthcare professionals. So we are building research activities along with Loughborough University and other universities to identify and how best we can able to improve this condition. So I told you about this is a chronic inflammatory condition. There's a delay in this condition, and that also affecting fatigue, which is also give a lot of mental health issues for these people. They are in the working life, productive life. They can't go to work. They can't earn. 59% of people with axial spondyloarthropathy experiencing mental health problem. Currently, we are doing a questionnaire-based survey in our unit to identify how it is different from other musculoskeletal conditions. So what is this condition? This is a condition as a spectrum of diseases where previously we call as an ankylosing spondylitis. Now we call axial spondyloarthritis, which is we have ankylosing or axial spondyloarthritis in one group, and there are various other conditions such as psoriatic arthritis or arthritis related with gut and eye symptoms are related to that sort of conditions. This spectrum of the disease is very well understood over the last few years because we divided them into a disease which has been picked up by MRI, not picked up by X-ray, which is called non-radiographic axial spondyloarthropathy, a disease picked up by X-ray as well as MRI, which is radiographic ankylosing spondylitis or axial spondyloarthropathy. Why we wanted to do that? Because there's a huge delay in all sort of things happening. Because when you have an MRI, it can be negative or it can be positive for what we call there is a joint which connecting from the spine into the hip joint. It's called sacroiliac joint, where the inflammation is predominantly this condition. Diagnostically, we can able to make that. So chronic back pain for more than 3 months, and if they are less than 45 years of age onset, if they have back pain associated with early morning stiffness, and the back pain is getting better by activity, worse by resting. There is another back pain, which is mechanical back pain, whereby you lift something, your back bends. That back pain gets better if you rest. Contrary to that, this one gets worse if you rest. So that's why you need to keep moving, keep active, or in fact, keep exercising. That will help. So what we are trying to identify, how much inflammation settle down in the sacroiliac joint. Sometimes X-ray may not pick it up. That can take a couple of years before it is been diagnosed. We wanted to diagnose these patients before they have any X-ray changes. That's why we are very good in picking up non-radiographic axial SPA, where only MRI is positive, not the X-ray. Now, there are other conditions. They can present to other specialties. For example, they can present into the eye department, eye casualty, with a bloodshot in their eyes. Around 50% of these people do have ankylosing spondylitis. In Leicester, our own cohort of patients, what we analyze is around 50% who present eye casualty have ankylosing spondylitis, but they're not picked up. So we started combined uveitis and rheumatology services, and we are the only service in the Midlands running the service, which we are proud of, whereby we were managed to improve the delay in diagnosis. Second thing is they may have skin problem, which can be associated with this condition. And also people with what we call inflammatory bowel disease or Crohn's disease, ulcerative colitis, they can also have this one. So they have back pain, which I told you about, inflammatory back pain, which is the pain which is better by activity, worse by rest. And they may have some swelling around the other joints, or they may have just a heel pain, alternating buttock pain, or sacroiliitis. These are the things which we need to. These are things the GP need to know about from you guys, particularly about the patient, to go and tell them, I got this back pain, and then I got swelling, I got the heel pain, I got skin condition. GP need to refer to us. But the problem is, still there is a delay from primary care to secondary care. When they come to secondary care, also there is a delay. So we are trying to address the delay in diagnosis as quick as possible. Because lots of people with ankylosing spondylitis have extra-articular manifestation. What I mean by that is they can have non-joint related symptoms, which is gut, skin, and eyes. You don't need to have the symptoms, but if one of your family members having either inflammatory bowel disease, psoriasis, or uveitis, and if you get inflammatory sounding back pain, then you need to seek help with your primary care and secondary care for us to understand. This is what the percentage of symptoms which you present. Predominantly eye problem is 40%, inflammatory bowel disease around 5 to 10, psoriasis is around 5 to 10% too. The other thing is about the gene. We are all saying that this is a condition genetically related. Yes, there is 80% of the people with Western population carries this gene, but not necessarily all the people carry this gene has this condition. However, people do diagnose axial spondyloarthropathy have around 85% will be positive for HLA-B27. 1 in 5 people, 15 people with the HLA-B27 positive go on to develop this condition, but not everybody. Over 100 genes are involved. However, there are some genes which is very protective of this condition, is called ERAP gene, which is again, it's very early stage for us to say that if you carry the gene, then you don't develop this condition, but we don't normally routinely just do this test. So to give a pictorial idea about that, because the back pain, which is, if you just imagine like a burger, right? If the burger is the meat in the middle, if they slip or bulged out, that is a slip disc. That is called mechanical back pain. I am not interested on that one. I'm a rheumatologist. I wanted to know what is happening in the inflammatory cells or the immune-related cells happening in this corner area or ligamentous joints. And you can see on the top, there is an inflammation. So I need to treat them quickly so that the inflammation doesn't spread into that and then completely fuse. You can see on the top, if you don't treat them, they'll fuse and then completely fuse. By the time, I may not be able to do any much help for them because they will be having restricted spinal movements. So that's what we wanted to prevent. How do we prevent this condition? Good response with anti-inflammatories. Otherwise, we need to go into very powerful medication, which is called biologic treatment, because these are the lesions. We see that in the this is sacroiliac joint. You can see the white thing, which is the inflammation. And then if we don't treat them, they erode the bone. And what happens is these biologic DMARD, which is the TNF-alpha blockers, IL-17 inhibitors, this is the only drug works better. Either they get better with non-steroidal anti-inflammatory drugs. If that doesn't work, then we'll jump into this very powerful, expensive treatment. For example, non-steroidal is only 10 pounds per week, whereas the biologic disease-modifying therapy is 10,000 pounds per year. In Leicester, we got around 800 patients on this group of drug. So just imagine how much money is being pumped in to treat this condition, because various drugs are approved because it's a huge impact in this condition for the patient personal health and personal life and the country's economy as well. So that's why a lot of drugs are approved now. But not least, that's why we wanted this patient to get better. Exercise is a key thing. That's what we did research, which my colleagues will be presenting later. And there's a key importance of exercise work as an anti-inflammatory effect to improve these conditions. A non-steroidal can prevent the radiographic or changes, but however, this is what we wanted to. The sacroiliitis can be completely treated by this biologic treatment. On the top, you can see there's a bone marrow edema on the top. Within 3 months, it's completely disappeared and become a normal. That's why we treat them. Within 4 months, they get dramatic benefit out of these conditions. And it also worked for long term There's a lot of patients in my group are up to 10 years, 15 years, they're on the medicine. Just imagine 10,000 pounds per year and how much it costs for the NHS. So that is very good drug. So what it is important is we need to seek help. And then the services around your area need to develop these services more. And we, Leicester, we've been awarded as aspiring to excellence for axial spondyloarthritis services by NASS, where we do continuous research and also improve the patient care. Not only I stopped there, I also collaborated with the Loughborough University with my colleagues, and we started doing a lot of research on that one. I'll stop here and I'll take any questions at the end of the session. Thank you.
Thank you, Moorthy. I will now share my screen. And do that. Okay. Okay, so I think now we know a lot more about axial SpA. If you didn't know it already, you can see why it's so painful, why it's so debilitating. And as Dr. Moorthy mentioned, exercise is something that is advocated, particularly to try and reduce that stiffness and increase some flexibility. But one of the things that we want to look at is whether exercise could actually be anti-inflammatory as an almost like an additional or a complementary therapy in AS. So as Dr. Moorthy mentioned, a combination of both medication and exercise is recommended. So we have these medications that Dr. Moorthy mentioned, the NSAIDs, the non-steroidal anti-inflammatory drugs, but also these, I put a pointer on, hang on. These biologics is very, very powerful, but quite expensive medications. And the way in which they all work is they actually stop your immune system from releasing those proteins that cause the inflammations, these inflammatory proteins, and they block it, they stop that happening. And as I said about regular exercise, things particularly like swimming and stretching, they're particularly recommended, mainly because traditionally they're there to increase flexibility and to reduce the stiffness and pain. So they're the main exercises that in the past have been those that have been recommended. Now, certainly there is evidence to suggest that if you are more active, then it can actually help delay the development of spinal immobility in axial SpA. So this is showing, this here is exercise in your leisure time. This negative shows it's actually a negative relationship. So higher levels of exercise in your leisure time seems to be related to a lower risk of spinal immobility, or that fusion that Dr. Moorthy was mentioning. Now, interestingly, this is also associated with higher indicators of inflammation. So this is something called CRP, and these are your immune cells, so your circulating immune cells. And this seems a positive relationship by which high indicators of inflammation, so higher levels of these, give you a higher risk of immobility. So there is definitely this relationship between your inflammatory markers and predicting development of spinal immobility. But really what's important here is exercise itself can be anti-inflammatory. It can lower your inflammation. And from other work that we've done, we can know that you have this sustained low-level increase in these inflammatory proteins in the blood when you've developed this chronic inflammation. This isn't something that disappears in a matter of hours or days, as would normally happen if you hurt yourself. This is something that's there over months and years. And you get this very low level but sustained elevation in these inflammatory proteins. And is usually assessed by levels of something called interleukin-6, this is one of these inflammatory proteins, or something called CRP. And what we also know, though, is that if you're more active, and this isn't necessarily just aerobic exercise, but also strength exercise as well, but higher levels of activity actually lower the levels of these inflammatory proteins in the blood. And now this is really important because it's not just about the actual area of damage that's occurring in axial SpA potentially, but we also know that these low levels of these inflammatory proteins that are in the blood over months and years, constantly there, are associated with developing things like cardiovascular disease, diabetes, and a whole host of other conditions. So it's really important because we know that exercise can lower these inflammatory proteins, and that also reduces your risk of developing things like heart disease in the future. So we know that these circulating inflammatory proteins are indeed related to an increased amount of activity. And this is what a study that was published about, 5 years ago now. And it was in about 2,000 males and females from many different ethnic backgrounds, and they were reporting their physical activity. And what they really wanted to concentrate on here was the amount of brisk walking type activity that they were doing. And they separated this brisk walking side of activity into 4 groups. And these 4 groups here, you've got quartile 1, 2, 3, and 4. And levels of activity increasing as you go from 1 to 4. So these people were doing a lot of this brisk walking type of activity. Here down this side, we've just got different types of inflammatory proteins. Interleukin-6 I've mentioned in CRP. TNF-alpha, this is one of these main proteins that's blocked by those powerful drugs that Dr. Moorthy mentioned. And you can see in each of these cases, as levels of activity increase, the levels of these inflammatory proteins are actually going down. So we know from lots of studies now that showing that the increased amount of activity can actually lower the levels of these inflammatory proteins in the blood. And it's really important because we actually think it's because when you exercise, it actually changes how your immune cells work. And your immune cells actually become less active, which means they produce less of these inflammatory proteins. I've just got a couple of studies to show you here. This is don't worry about the numbers, just measuring immune cell activation. This is a study of 9 weeks, just 9 weeks, in older women who were doing resistance or strength training. And you saw a significant fall or significant decrease in their immune cell activation. And that was related to having less of these inflammatory proteins in the blood. So this was a supervised study. But even if you just look at a cross-sectional comparison of people who are active versus people who are inactive, and again, this is in older women, they found that people who are regularly active have much lower levels of immune cell activation. And again, this translated into lower levels of those inflammatory proteins in the blood, which we know are really crucial in terms of axial SpA, but also increased risk of developing other conditions as well. And although those 2 studies I showed you were in healthy people, this is some of our data from people with long-term conditions. And this is actually in people with chronic kidney disease. That's one of our other collaborations we do with the hospitals in Leicester. And we got people to build up to walking to around half an hour a day. It didn't have to be all at once, it could be split up. And they did that on most days of the week. Now, these people, again, were very fatigued to start off with. These people, to start off with, could barely walk down to the end of their driveways, and some of them were struggling just to walk around their houses. But by the end of the study, what's really gratifying is that people were able to walk on the beach when they're on holiday. Some people were able to go out and walk the dog with their partners they weren't able to do before. So this is like the hidden worth in what we're doing. From a physiological point of view, one of the things that we found was that when you looked at these levels of inflammatory proteins, now this interleukin-6 is pro-inflammatory and this interleukin-10 is anti-inflammatory, actually switches it all off. And what they found is in our regular walkers, not going forward now. There we are. Our regular walkers, we actually found that the inflammatory proteins decreased. We actually saw a decrease in interleukin-6, more interleukin-10, and their inflammatory status was lowered. Yet in the ones that just did their normal activity, which in this group tends to be not much just because of their own functional capacities very low, there was no change. There's this positive anti-inflammatory effect in this chronic inflamed group. So why isn't it being looked at in AS? Well, this is really odd. And this is something where when Dr. Moorthy first chatted to me probably about 5 years ago now, we were thinking, well, there's really good reason for investigating this in people with axial SpA. It's an inflammatory condition. We know that blocking inflammation forms part of the treatment. So we know that exercise could potentially complement or help with this. we know that people with axial SpA have reduced levels of physical activity. And we know that people with axial SpA also have a higher risk of developing cardiovascular disease. So there really is a good reason for looking at this. But until we started looking at no one really had started looking at these anti-inflammatory potential of regular exercise in people with axial SpA. If you delve into the literature, there is a few studies out there, but they're really well hidden and perhaps not so well controlled. It's probably the first one that came out. It's only in 24 people. The paper doesn't really say what the exercise was, so I don't really know what we can take from it, but it's maybe a cautious entry into looking at this in a little bit more detail. You've got two of these inflammatory proteins here, interleukin-6 and TNF-alpha, and this exercise, whatever it was, it seemed to, after 12 weeks, there seemed to be an overall trend of these inflammatory proteins decreasing. There wasn't a control group, so we don't really know if this was just circumstantial, but certainly maybe we can take some initial encouragement from that. Now, since then, there's probably there's one other study that I found that didn't actually set out to look at inflammatory proteins. They were looking at disease activity and endurance and strength, or aerobic and strength exercise. And what they report is in this group of 24 people on a mixture of biologics and NSAIDs, they found that the disease activity, these are all different markers of disease activity, was lower after 3 months of exercise in the exercise group and didn't really change in the control. And this was all very, very, very positive for this particular program that they were looking at. And then later in this paper, really hidden, actually in some supplementary appendices, you really had to find it, there was some data on inflammatory cytokines. They don't really mention it at all. It's kind of like just apologetically thrown in. And one of those is interleukin-17A, which is really important in the development of axial SpA. And it just shows that it did tend to be lower in the exercise group. So again, there is some very early information suggesting there's good potentially for our exercise to act as almost adjuvant or complementary therapy to those existing medications that are already out there. So we need studies focusing on this anti-inflammatory potential. We need to actually harness this and take this further. These treatments cost a fortune. So if there's anything that we can do to make them work better, plus gain those quality of life benefits from being more active, then it's certainly something we should be doing. And that's what we've just been doing recently. So we've just completed a study called the Ecstasy study. I'm not going to talk any more about that. I'm going to hand over to our researcher, our postdoctoral researcher, Dr. Matt Roberts, and he can tell you a little bit more about what we found. Thank you.
Thank you, Lettie. Let me just share my slides. So just to check, can you see my slides properly?
You're in presenter view.
Oh, good. 1 second.
That's it.
Yeah, thank you. So hi everyone, I'm Matthew Roberts, and today I'll be talking about exercise as an anti-inflammatory management in axial spondyloarthritis. Although I'm presenting, I just want to say a massive thank you to NASS for funding the project, and also to Malik Kamrouni, Victoria Lindsley, Moorthy and Lettie, obviously for helping out with the study as well. So let me just mute this. So what we're going to do is we're just going to introduce the study before talking through the methods, results, conclusion. And we'll also present some of our patient feedback and discuss the next steps. And then just after this as well, we've got some of our actual participants who took part in the project, and we'll do a bit of a live Q&A session in terms of their feedback on the study as well. So just to pull everything together before we talk about the study itself, as Moorthy said, we've got this inflammatory disease that affects around 1% of the UK population, but it might actually be a much higher prevalence because of that delay in diagnosis. And it results in this significant pain and loss of mobility, with the symptoms typically occurring when people are in their 20s in the first instance. So then what happens is this inflammatory profile significantly affects their pain, etc., they don't have good work productivity because it's affecting their 20s. And it also influences things like forming social connections. And men typically suffer symptoms around the spine and the hips, and women typically get it in the peripheral joints as well, including the hands, feet, and neck. And as Moorthy mentioned, there's 3 steps to management in terms of managing AS. And the first step is normally physiotherapy, and then it's these non-steroidal anti-inflammatory drugs and biologic treatment. But this first step is often overlooked, which is why we want to investigate it. So everybody has got white blood cells, and within your white blood cells, there are these things called monocytes, and they're very good at helping fight infection, but they're important to look at in the context of AS because there's 3 different subsets. You have these classical monocytes, intermediate monocytes, and non-classical monocytes, and they have these surface receptors. So you can see here, this one's got kind of blue question marks just to illustrate it, but that's CD14 markers. And you can see in the intermediates, they've got a bit of this CD14 and a bit of CD16. And you can see in these non-classicals, they don't have much CD14, but they've got a lot of CD16. Now, the reason these are so important in people with AS, these 2 subsets, these intermediates and non-classicals, are a major source of those pro-inflammatory cytokines such as IL-6 and TNF-alpha. And those cytokines are what go around the body causing inflammation. So if we can reduce the proportion of these monocytes in the people's blood, in theory, we can reduce inflammation around the body as well. And that's shown here. So in other populations, so people who don't have AS, what we see is that these CD16 positive subsets are actually elevated. And that includes people with atherosclerosis, obesity, and cardiovascular disease. And this is what we see in the lab. I won't explain it too much today, but you can see you've got 3 different populations here. And it's these 2 populations which we're interested in reducing because they're the pro-inflammatory monocytes. But what we do know in other populations is that we can reduce the proportion of these with things like weight loss and exercise. So that pulls us onto our study because we've got this population with chronic inflammation, but we know that exercise and lifestyle modification can actually help reduce the pro-inflammatory monocytes. So therefore, the present randomized control trial, the ecstasy study, investigated whether exercise reduced the relative percentage of these CD16 positive monocytes in response to 12 weeks of home-based walking. Now, the reason we selected walking is because it's quite easy for people to do. They can fit it into their lives quite easily. They don't have to have access to specialized facilities like a swimming pool. And also, as I'll mention later on, people could break up the walking as well. So you could accumulate the total walking in your own time. That could be getting off the bus a stop earlier, for example, and just walking that. And we also took subjective measures of disease activity, physical function, spinal pain, and work productivity through a series of questionnaires to supplement the blood findings. So the methods, what we did is we recruited 20 participants who'd been clinically diagnosed with axSpA from one of Dr. Moorthy's clinics, and the people were receiving stable anti-inflammatory drug treatment and did not perform purposeful exercise, which was confirmed through a questionnaire. Everybody was over 18 years of age, they had no cardiovascular disease comorbidity, and they're receiving this stable dose anti-inflammatory drug treatment. We had nobody that was on this biologic treatment, nobody that was excessively active, which we measured through activity monitors, and they had no contraindication to the study, so no physical or psychological barriers. Now, in terms of the study, what we did is we recruited people from Dr. Moorthy's clinics and screened them just to make sure they were able to take part. And then the main visits all happened at Loughborough University. And what happened is the night before, people would fast from 10 o'clock the night before their visit, because that's really important when it comes to the blood markers which we're looking at. And then the morning of the visit, they would come in and fill in a series of questionnaires to do anthropometric measurements. That includes things like height, weight, body composition, including waist and hip circumference and body fat. And then after about a 10-minute rest, we'll take a blood pressure and a blood sample. And this is how we quantified the monocytes. And then also what we did is we did some exercise tests, including sit-to-stand tests, where people would literally arms crossed, stand up in order to measure their physical strength in their legs. And we also did some exercise tests to make sure that people were comfortable walking and that they could relate to a pace which was somewhat hard, which we'll come into it later on. And at the end of this visit, the individuals were randomly assigned into either an exercise group or a control group. So you can see this here. They went through this consent, activity monitoring, baseline assessments, and this randomization. So then what happened is the people either went into a control group or an exercise group. The control group were told to carry on as normal, don't change anything at all in your life. The exercise group were told to do 30 minutes of walking 5 times a week at a pace which was somewhat hard. So we got that from the treadmill, but the individuals were also given an activity monitor, where they could measure their activity. Then every 2 weeks, I would contact the participants just to make sure they were happy to carry on. And every 4 weeks, the individuals would come back and repeat these measurements here. So they do disease activity and symptoms on the questionnaires, they do the blood and physical function tests, and self-reported activity. So everybody would come back every 4 weeks, and then they'd finish the study. The people in the exercise group were given an activity diary to help log the exercise itself. So they got these activity bands that are a bit like Fitbits to get worn around the wrist, and they'd write down the date, the exercise duration, so how many minutes they did, overall RPE, which is how difficult it felt. Remember, we want people walking at a pace which was somewhat hard for themselves, and the distance covered. And at the bottom was a comment section for any reason why they didn't do the exercise. So it could be icy conditions outside, it could be just a lack of time or a disease flare-up, for example. But importantly, the 30 minutes of walking could be accumulated. So you could break it down into 3 10-minute bouts, for example. Now, in terms of the questionnaires, our participants who are in the crowd probably dread looking at this because they filled them in so many times. But what you can see is you've got the disease activity index here, and you can see a series of questions such as how would you describe the overall level of fatigue and tiredness you've experienced from none to very severe. And you've got a series of questions that they fill in. A lower score is better, a higher score is worse in terms of disease activity. And it's the same for this physical function test over here. So this asks questions such as how difficult is it to put on your socks or tights without any help, from none to impossible. And again, the lower the score, the better it is. Here's just 2 more questionnaires which we handed out. So one was a health index. It asked questions about this moment in time. Is there pain that sometimes disrupts my normal activities, and so on and so on. And if people agreed, that was essentially 1 mark. The higher the score, the worse their health is. And then this is a question just about work productivity, because as Moorthy mentioned, a lot of people with AS have time off work, for example, if you've got flare-ups or work part-time. So that was just asking about work productivity as well. Now, in terms of the results, what I'll do is I'll talk through all of kind of the individual findings, but all of the findings kind of follow this template. So what we've got here is we've got the control group and the exercise group for each outcome. And I'll go on to the next slides in a second. But what you can see is that each cross is an individual participant in that group at the pre-visit. So that's at week 0. And the post-visit is week 12. And what you can hopefully see here is you've got the group mean here, pre and post. So the group mean for the disease activity index went up slightly in the control group and came down slightly in the exercise group. But this wasn't a significant finding because you can see it's quite messy in terms of individual responses. And it was the same for this physical function questionnaire as well, where you get a slight increase in the control group, a slight decrease in the exercise group, but it doesn't come out as significant. Now, that's not novel because other studies have looked at these questionnaire data in the past in other groups. What you can see here is for the spinal pain, this did come out as significant. So you can see in the control group from pre to post, spinal pain increases in the control group, but you can see in the exercise group, it comes down. And although that doesn't look like a big change, the scale is only from 0 to 10. So the control group are going from 2 to 3, the exercise group are coming down from 3 to 2. So it is quite a significant change in terms of overall spinal pain when you look at the context of it. But there's no significant findings either for the health index or work productivity. Now, as I mentioned, this isn't a novel aspect of the study because other studies have looked at questionnaire data. The real novel aspect is those inflammatory monocytes, which I'm going to talk about now. So the first one we've got are these classical monocytes. And these are the classical monocytes which we wanted to increase, because if the proportion of these classical monocytes increases, and these are the ones which aren't pro-inflammatory, it must mean that the pro-inflammatory ones are coming down because it's proportion the total monocytes. And what you can see is you can see all the individual responses. And in the control group, what you can see is most people are getting a reduction in the number of these classical monocytes. And it's actually about a 10% reduction, which is actually quite significant. In the exercise group, again, you can see these individual responses, and most people are going up with the exercise. So remember, this is just 30 minutes of walking 5 times a week for 12 weeks, and you can just fit it in around your life. So nothing too difficult to fit in. When it comes to the pro-inflammatory monocytes, the intermediates, there's always a very low proportion of them. So you can see there's only about 5 or 10% in people's blood. And actually not really much is going on with these, but that's not surprising because the proportion's so low. But what you can see is these really pro-inflammatory monocytes, them CD16 positive ones I was talking about before, which are elevated in people with disease. You can see in the control group, most people are getting an increase in these non-classical monocytes. And you can see the group mean here is going up as well. But in the exercise group, it's coming down quite significantly. In most people, this person had a slight increase, but most people are coming down. So then if you put all three together in the context of the exercise group, you can see that the exercise group are getting an increase in these classical monocytes and a decrease in these non-classical monocytes. So what's essentially happening in their blood is they're getting a decrease in these pro-inflammatory monocytes and an increase in the ones which aren't pro-inflammatory. So over time, that's kind of changing the makeup of the monocytes in their blood, and hopefully over time should reduce the amount of these pro-inflammatory cytokines which are going around the body causing inflammation. Not much happened with these intermediates. So the conclusion of the study is that regular walking reduces the pro-inflammatory immune cell populations in axSpA, which coincides with favourable spinal pain responses compared to a control group. It highlights the importance of regular exercise to improve these underlying inflammatory profiles in patients with axSpA. And that's really the novel aspect. We presented this so far at 2 conferences, and at both conferences we've won an award for the study as well. So it just shows you kind of the uptake and the interest in the study as well. Now, in terms of the participants, what we were expecting before we ran this study was around a 10 to 15% dropout. That's normally what we'd expect in studies which are happening over 12 weeks, and they're quite demanding. Most people are traveling kind of 30 minutes to take part in the study. But interestingly, we had a 0% dropout in the study. So there's a really good buy-in, and actually this was a proof of concept study. So we were checking that people could take part and did want to take part, and there was a 0% dropout. So no one kind of said, Matt, I don't want to take part anymore, I'm going to drop out. And here's just some quotes that we've got to do the study as well. So by taking part in the research program, it's allowed me to gain knowledge on AS. It was quite surprising that a lot of people didn't fully understand what AS was. It's inspired me to continue with additional exercise. My family are now more patient with me and understand that AS is a disease worth taking seriously. That's a good one because they actually had children who were rushing them up and down the stairs. So their family was actually being more patient with them. The exercise program motivated me to push on with exercise when I would have usually been quite inactive. The exercise has definitely helped me physically and mentally. And I used to have a gout flare-up every few weeks. I've not experienced a single flare-up during the 12 weeks on the exercise arm. And in terms of the next steps, what we're trying to do now is, this was a proof of concept study, so quite small scale, but we're trying to secure new funding to build upon this existing work and expand into them people who are on that really strong medication, that biologic treatment. And also, because we now know that people want to take part in the project, we want to significantly scale up the number of participants. That was only 20 people, we want to scale it up. And also in the future, what we want to do is team up with a group called Yoga for AS, and what they're going to do is provide yoga exercises for the control group, because some of the feedback that we had from the control group is that they actually wanted to do something, some exercise or stretching. So hopefully in the future we can team up with Yoga for AS in order to deliver this as well. So thank you very much. And I just want to say a massive thank you to UHL, the NIHR Leicester Biomedical Research Centre, the National Centre for Sport and Exercise Medicine and NASS, and of course to all of our participants, because none of this would have been possible without them. So thank you very much. I'm just going to stop sharing my screen. And at this moment, I'm going to invite some of our previous participants to turn on their cameras and mics, and we'll have a live Q&A session. So I can see some of you hiding in the chat. I can recognize a few names. So if anyone wants to come forward, we'll have a little chat. Alison, do you know if people can unmute their mics, or is it just co-hosts?
I will. Do you know any names at all that you would like to unmute, Matt?
Some people might be coming under different names. I'm expecting Amanda, okay. Steve, these people that put themselves forward.
Right. No.
Steve, I can actually ask them to unmute. So you've got Steve Hughes.
Yes, you should be able to as co-host.
Yeah.
What's my video stopped?
Hi, Matt.
Hi, Steve. How are you?
Yeah, good. I've lost the picture, but we've got the audio.
Yeah. So I'm just going to wait for a few more people to join, Steve, and then we'll just kind of get your thoughts and feelings of how the study went, etc.
Yeah, no worries.
Just while we're doing that, we can have a few of the questions, I think, which are probably going to be directed at Dr. Moorthy. So I have a question here from Angie. Dr. Moorthy, I think I know the answer to this one, but can it present as an acute disease, like as a result of an infection like COVID?
Yeah, thank you. There is no particular study looking into whether COVID has brought some ankylosing spondylitis or axial spondyloarthropathy. But there is a group of people, what we call reactive arthritis, by which they have some inflammatory process happen before, some years ago, and then they can turn on later to develop this condition called axial spondyloarthropathy.
Thank you, Moorthy. And then I've just got a couple of questions, both of them related to CRP. So what are typical values for raised CRP in axial SpA patients? And then does inflammation always correlate with high CRP or ESR?
Very good question. That is a main problem which we are facing diagnosing this condition. It's not always correlate with elevated CRP, because it's a condition comes and goes. In other words, it's an episodic nature of inflammation, comes and goes. That's why when they go and see the GP, the CRP may be normal. GP won't refer to rheumatology services, though they have a typical symptom. And coming back into the rheumatoid arthritis, for example, we always have elevated inflammatory markers, which actually correlates with the current state of the joint symptom, but not in ankylosing spondylitis or axial spondyloarthropathy. Then the question is about how much it will be elevated, because it's usually normal range is around 5 to 10. We would expect 3 to 4 times above normal limit, but not always the case. And it doesn't go up more than 100 or something like that. It's very high elevation of inflammatory markers doesn't happen.
Excellent, thank you. And I think the whole problem with the inflammatory markers is that it's so individual, isn't it? There's not
Yes.
one on its own that's predictive of disease severity. So it's one of those awkward things. And some people can have higher CRPs and not have as bad symptoms. It's unfortunately it's not as easy as it could be. So Matt, have we got?
I think we've got Steve.
Yeah.
Tim, are you there as well, Tim?
I'm here, yeah.
Nice. And Amanda?
I'm here, Tim, yes.
Amazing. So we've got 3 of you.
Thank you, all of you.
Thank you very much for doing this.
Thank you.
We've got a few more people in the participant crowd as well, but not everybody likes to speak up in front of such a big crowd. So I'd just like to know from Amanda, Steve and Tim, kind of talk me through the process of how you originally got involved in the study. Obviously, we're going to Moorthy's clinics, but how did you actually get involved in the study in the first place? Do you want to go to Amanda first, and then Steve, and then to Tim?
Okay. I loved finding out about it because, to be honest with you, I didn't just want to have backache, and I didn't also want to be on tablets, forever. So when I was offered the place to go and do it, I've just found it fascinating, and it really has changed the way people think, how you explain your condition, how you live your lifestyle. Without it, I just think I would have been going along, having the tablets and thinking, well, this is how it's going to be. But the truth of it is, I feel now I've really got a very, very good lifestyle back due to what I've learned and done. And the exercise, I've had so many good months, whereas before I didn't have many good months, but now I seem to have a lot of good months rather than just bad ones. I do more hours at work, I exercise, I feel better, I look better, and that's just 100% the best thing I ever did, going to that group.
Yeah, I know you've mentioned to me as well that you've picked up a bit of cycling as well.
Yeah.
So of course, it's not just about the walking, it's about changing your lifestyle and picking up these other exercises as well.
It's social. There's so many things I do now I perhaps wouldn't have done before. You do kind of like go into a bit of a shell and you get into bad habits. So when you start to look at it, you break that cycle and you start doing new things. As I'm now in a cycle group, I'm hoping to start jogging again. I used to jog years ago. I'm doing little bits on the treadmill, but I exercise every day. I've lost quite a lot of weight, and it's all good mentally, physically, and I have a lot more energy.
Yeah.
So you know, and it's all down to finding out and doing the study. And I would recommend anybody can do this, make time, because it's absolutely, it's priceless, you know, and everybody works hard at it. And I hope everybody like gets out of it like I have.
Yeah.
You know, that's my experience.
So that's one of the things that kept coming up, because obviously we've not really got these measures of the psychological well-being in terms of mental health. One of the key things that I was getting from conversations with people in the lab was the mental aspect of it, in addition to the physical aspect that people were seeing responses to what's going on in the inside as well. So if I go to Steve, what's your thoughts, Steve? What got you involved?
Hi, Matt.
Hi, Steve.
Yes, originally it was I lost a lot of vision in my left eye, and went to the eye clinic, and they diagnosed I've got this rogue gene. So that was the start of the issue with the AS. And also what happened then was it came back, but that introduced me to something I'd never known before. So I was keen to really get to know what it was all about, and I gladly, through Dr. Moorthy, I gladly wanted to go on the case study.
Yeah.
So obviously I was in the non-exercise group, as you know, but for me, I'm probably a good advert for your case study, because I'm very active at work, as you know. I'm a builder, and I'm up and down ladders and pushing wheelbarrows and whatever. But I didn't do any exercise per se, because I felt that the exercise was enough what I was doing at work. Yeah. So in relation to that, when I sit down in the evening, I stiffen up so much that it's very difficult to unstiffen myself, get around and such. So, you know, it's absolutely right that exercise would help with the sound of it.
So have you tried to introduce any exercise into your lifestyle?
I went to see a physio at Loughborough Hospital, and she put me in touch with some exercises, but me being me, I'm sadly I'm not doing them yet. Yeah,
that's where that NASS website will come in very useful, because it's got a lot of exercises on there that you could incorporate into your life.
Yeah, you know, like everything, I really ought to start, but you know, one of these.
How about yourself, Tim?
Well, same really. I mean, main part of taking part of the study, I just wanted to help, just to help others really, to learn a bit more about the condition itself. And I mean, how you've explained and done that presentation, then obviously you sent me the information on my personal circumstances. And I did say that, you know, I mean, it's hard to make head and tail of it because it's quite technical for someone like myself. But how you've just explained that, you know, I mean, in your presentation, I'll be honest with you, have I done any exercise? Because obviously I was in the control group as well, so I didn't do any form of exercise. Have I done any since, you know, since seeing yourself? I haven't, I'll be honest with you. But since then, I've noticed I have had more sporadic days off work. And like I said, now that I've seen that information, you know, how you've put it and explained it, and seeing those graphs, you know what I mean, and seeing the inflammation decreasing, it's given me a kick up the backside, you know what I mean, to actually make an effort. And like I say, it's sometimes you have to see it to think, oh, you know, because you hear a lot, you know, everybody's different and everybody suffers from certain symptoms and that, but seeing it just makes you suddenly think, you know, come on, it is time to start making a change. You know what I mean? So yeah, I've definitely, you know, thinking about joining a gym and also, you know, just for the simple fact that I think the problem is we find it hard to get motivated because we're in pain. You know, we're concerned about causing damage, you know, because of the inflammation. Because if you're in pain, you think, am I doing any more damage? But like I say, I personally haven't put that into effect at the minute, but it's definitely an eye opener for me. And yes, going forwards, that's what I'm going to do.
Yeah. One of the things that we always try and say is that just doing something is much better than just doing nothing at all. So in other populations, not with AS, we found that even if you just do something, it massively improves inflammatory profiles. And actually, the people that are moderately active to very active, there's not that much of a difference between them people compared to the people who are inactive to lowly active. So just doing something will be much better than what you're already doing.
Yeah.
And actually adding on to that one, Tim, there's an awful lot of stuff, this recommended exercise, and actually don't worry about that. And also someone, and Tim and Steve and Amanda, you might be able to help us on this one. And one of the questions actually is kind of related to that is when you're in flare-up, it's very hard to exercise, and it can last for obviously a long time, weeks. Do you guys have any particular advice? I mean, our view would always be, if you can just do something, it's better than nothing. Don't worry exactly what it is. But what about, you're the ones who are the experts in this. I think
stretching, even if you really are having a bad flare up, just do some stretching. There's nothing that you can't do while you're sitting in bed, or just have a walk around. Just every 20 minutes, make sure you get up and walk around, walk to the end of the garden. That's what I try to do, because since I've been exercising, my flare-ups haven't totally disabled me, whereas before they did. So I know that you need to find time. I know we all live busy lives, but 5 minutes, 20 minutes, if you can, a day, if not even 5, anything's better than nothing. But that's how I feel about it. That's what's helped me, and I cannot tell you how good I feel. I mean, I sometimes don't have to take my tablets, and it feels so good. I think I can get away with it today, and then other days I do. But I just think to myself, just listen to your body, listen to your brain, and just think, there is light at the end of the tunnel. It doesn't have to be a bad thing. It's just something you're dealing with, rather than it's stopping you in life. You just have to work with it. That's how I feel about it.
That's great. Thank you. That's really valuable. Thank you. And that kind of also hopefully would help Gary, who's asked what exercise is best for someone like me who has a completely fused spine. And I know there's lots of information online, particularly for stretching and core exercises for people with completely fused spine. And Dr. Moorthy might have something else to say. But again, we would just say, listen to your body, and anything that is possible to do, something is just better than nothing.
Yeah.
I mean, the hydrotherapy is another one, the aerobic exercise, hydrotherapy. If you have a fused spine, then walking in the water, you're doing exercise, but you are in a wet environment, which also help you to improve the resistance and also help. So traditionally, all the hospitals have a warm water pool where we put our patients into the hydrotherapy sessions and see how they are coming out. So, I mean, you could find a nearest to swimming pool where there is a reasonably warm water rather than a cold water. If you do some exercise of walking, stretching, which should help you. But once it's fused, I'm afraid it's only to improve the pain, stiffness, as well as the fatigue. These are 3 things can better by hydrotherapy too. Thank you.
One thing that a lot of people do as well is literally just hot water bottle onto the point of pain. I heard that from a lot of people that were taking part, just to relieve symptoms as well.
Yeah, that's the one for me.
Yeah. I heard that quite often, Steve.
You did, yeah. Yeah, my difficulty with walking was that I get a lot of hip pain. So I can only probably go 1 mile, 2 miles before it starts kicking in and stopping me from going any further. So the walking side of it's a difficult one.
Yeah.
But sure to try all the rest. Anything that helps, I shall get into. Yeah,
it sounds like stretching exercises might be a good one for you, Steve. You'd be able to fit into around your life as well.
Can I just ask one question?
Yeah, go on, Tim.
It's obviously changing the subject a bit, but has there been any more look into in regards to diet and things people are eating? Because obviously that seems to be cropping up a lot as well.
That's something that is being looked at more, especially as some diets can be pro-inflammatory. And so that is an area that is getting a little bit more attention. Again, it seems like a lot of the lifestyle stuff in AS is lagging behind so many other things. And that's something that needs to be addressed. So, Matt, have you got anything you want to add
I reviewed this literature about a year or two ago, Tim, and I only highlighted 5 studies which had looked at diet in terms of people with AS. Of them 5 studies, 3 of them were looking at probiotics, and the findings weren't that strong, but the way the studies were run, they weren't controlled very well. One of the studies looked at starchy foods, which I think you've read about. I think you were telling me about this in the lab that time, kind of these starchy foods that bring on inflammation. But again, the studies didn't really have rigorous control groups. So it's hard to kind of investigate the exact mechanisms which is going on. But I know there's more interest in this area. And actually, one of the presentations which we did recently, one of the questions from the crowd was about diet, and that was from someone that's a consultant in sports medicine. So they've got an interest in it as well.
All right. Okay.
So the diet is a very big area. It's very difficult to do a study. Sometimes it's maintaining the diet history is also very difficult. So lots of interest in diet and anti-inflammatory effect, particularly for axial spondyloarthropathy. There is a lot of literature to suggest there are 50% or less than 50% of people which have some sort of a gut inflammation, which may predispose this condition of axial spondyloarthropathy. So they have subclinical gut inflammation. So to improve the gut inflammation, there are certain diets, particularly the probiotic yogurts and some less starchy diets are really helpful. There are few literatures, but not a huge literature. The reason behind that is having a dietary cycle or a history, and then putting all the patients into different diets is sometimes difficult.
Thank you.
Thank you.
So I've just got another question for all 3 of you. Obviously, I think this was the first study that any of you had ever taken part in from memory. But were you kind of nervous to take part when we first met in one of Moorthy's clinics?
Yeah, I think I was nervous. Yeah, it was a bit daunting because I felt so unwell. I wasn't sure I'd be able to be any help, but it's the advice that I found helped me more than anything. I've loved listening to all of it. I love looking at those graphs. They make it in a like, obviously you would understand them kind of graphs, but you put it across in a simple way that's easy to pick up, and I can relate to all of that.
That's good to hear, because one of the things we're always concerned about is going a bit too scientific.
No, I was fine with it. Really keen to learn more about what was going on inside my body. So yes, I wasn't nervous at all, and I'm glad you put me in the non-exercise group anyway. But yeah, I was fine. I was absolutely fine.
Nice.
Not at all.
Yeah, I was exactly the same. Not nervous anyway whatsoever. Plus, it gave me some. Unfortunately for you, you had to get up early on a Saturday morning.
Yeah, that's true, to run the lab visits.
Yeah, but that's, like I say, it was. Yeah, I mean, I had to travel a fair distance, but it gave me something to do on a Saturday. And to be honest with you, it was one. The first time I've been on a treadmill for as far back as I can remember. So just the fact that I was doing some form of exercise on those specific days, it was, I enjoyed it, to be honest with you.
Nice.
It was nice to take part in something. And like I say, the main thing is if you can get data from me to help other people, then, it's the best way forwards, because people who don't come forwards for these studies, we're never going to get the information that we need to move forwards in the future. So
absolutely, yeah.
Absolutely.
So what just one last question I've got for all 3 of you is just what did you take away from the study in terms of how did it change your life? I know that's a bit of a big statement, but did you change anything with your life in terms of exercise or anything?
In regards to me, like I say, I'll be honest with you, the same as the lady was saying earlier, we live busy lives, we all do. When I go to work, I obviously start early, so trying to squeeze, as I mentioned on the trial thing, I do walk my dog every day, and I do the same things every day, but I'm not sort of going above and beyond. I could do a brisk walk. Do you know what I mean? When I'm walking the dog, I should get myself out of breath a bit more. So just little things like that, I am going to start putting into effect. But to be honest with you, since the study, I haven't done that. But It's we get caught up in this world, don't we? You know, we're rushing around. You know, we never put any time aside for things like that. But like I say, after how you've put that presentation together there and explained it in simple terms, there's evidence there that it does help and it does work. So it certainly gives me a kick up the backside to get sorted.
And I know you mentioned, Tim, as well, you've transitioned into more of like an office-based job now as well. So it could just be something as simple as breaking up your sitting time at your desk and just standing up every now and again.
Funny you say that, because I've literally last week I've put a letter in to say that I am going to go back on the road, because you know, obviously I'm an HGV driver, and yes, there is a lot of sitting involved in HGV driving, but since I've been in the office, I do no physical exercise whatsoever. So I'm actually going to go back on the road for 2 days a week, because then I'm getting some form of physical, you know, getting myself out of breath, because like I said, there is manual labour involved in it, and I'm going to do that. And in all fairness, work have been brilliant. They've given me that opportunity so that I can break my week up. And at least, even if it's only 2 days a week, it's 2 days more physical exercise and get myself out of breath and movement. So that's what, I have made that change, because like I say, hopefully within the next 2 weeks, I'll be back on the road doing 2 days a week of, you know, some form of physical exercise in a way. So I have made a change thinking about it. I forgot to mention that. So yeah, that's one thing I have actually changed. Plus the mental side of things, like I say, you get stressed sitting in an office, and now I'm going to be out and meeting more people, and like I say, that side of it is going to hopefully make me feel better. I'll let you know in 6 months' time whether it was the right decision or not. But
yeah, I look forward to hearing from you.
One of the things that's coming up in the chat quite a lot is this fatigue, and I know that's something that we've all three of us have talked about a lot. Has anyone got any thoughts in terms of dealing with the fatigue? Any of the patients, any ideas? And did the exercise actually help with feelings of fatigue?
See, the problem, sorry to put in again, the problem with me with fatigue is I tend to get up about 3 o'clock every morning, and because obviously I have to be at work early, and I've always put the fatigue down, because I've done this job for 13 years. I've always put fatigue down to the simple fact that I'm just getting up early. But the more I think about it, I might be suffering from fatigue from the illness itself, and it might not just be the fact that I'm getting up early. But that, I don't think that helps in any way whatsoever. But that to me is where I always put my fatigue down to. I don't put it down to the condition. I just think, well, it's because I'm up early, and you know what I mean, it's just my job that makes me tired. But I haven't done anything to improve it in any way, and I don't know ways of doing it other than the exercise side of things. Like I say, it might improve it if I start exercising more, but like I say, until I start doing that, I can't answer that.
Yeah, and of course, Steve was in the control group as well.
Yeah, I've never really thought I suffered with fatigue. I just basically put it down to the job I was doing. But I do seem to now know, after the study, that I do get a certain amount of fatigue. By the time I get home in the evening, I'm absolutely shattered. But I tend to try and push through it, just to get work done and get home. And so I've not really tried to do anything other than carry on, really. Yeah.
Amanda's just had to leave because she was on a break from work, so she had to go back to work now. That's why Amanda's disappeared. I have had emails though from people who can't attend today saying, I had one email essentially saying that they hadn't been doing the walking, and this week has done one walk, and they said they remembered kind of the psychological aspects of it and how uplifting it was in terms of energizing them as well. So that's one of the emails I've had from somebody else that took part. So some people are definitely finding that the exercise is helping energize them in terms of different aspects of life as well. That obviously helps with work. Amanda, you're back.
I'm back, yeah. My phone just disconnected. I just think all I can say to anybody, just try it once. If you don't like it, I would be straight away on the next exercise class. I would do anything, because the difference it's made. I know it is hard and we all work and we can't be bothered when we get home, but the better weather's coming, just the nights are changing, just get out there and just start walking or stretching, and within 2 weeks you'll be addicted like I was.
Well, Amanda, what about in terms of fatigue? You might have missed that one. So
Yeah, I did.
Do you think exercise helps with fatigue?
Oh, absolutely. Yeah, no doubt about it. Whereas before I'd, go home after work and I'd just sit down and have no energy. The exercise, it just gives you a bit of oomph. To me, it really gives me a lot of oomph. And I'm doing things and I'm seeing people that I don't usually bother seeing. Since COVID, we've all changed. And now it's like, I'll meet you Friday. I'll meet this one Thursday. I will go before work. I will go after work because I've got more energy. There's no doubt about it.
Yeah. So I don't know if Lettie or Moorthy, you've got any questions that you want to ask Tim, Steve, or Amanda?
I just want to thank you all for doing the study in the first place. I mean, it's blown us away. Like you guys, when you were coming into the lab, your enthusiasm for it, it was just fantastic. And yeah, I just want to thank you.
I'll put my name down for the next. I'm there.
I always make sure I thank you all on the presentations that we do as well.
Yeah, thank you for those participating in the study, and really look forward to very positive, feedback from you guys. How we clinicians looking in a different aspect, and researchers looking to this different aspects, and what you as a patient, and we are here to improve the patient care. What do you hear from you? How best we can, one of the things which we are still working on is how to improve the fatigue in people with whether they are taking medications or not medicines, or even a powerful medicine. The fatigue is a very difficult symptom to measure and to treat for clinician as well. So if the exercise answer the question, there's a huge plus for our patients. And that's what we're looking for. Thank you once again for your time and joining this meeting today. I'll hand over to Lettie.